Please welcome Dr. Raphael.
So, thank you. I also had a wise professor, and that professor said that if you don't have enough to speak about in a half an hour, what you do is you mess up your slides. It takes you 15 minutes, and you finish the half hour right on time. So here I am, and the introduction that you just had actually dovetails into exactly what I'm going to talk about. Is if in this case we were talking about a patient with anemia before here, and they said, well, if it's just the red cells, it could be a lack of the building blocks, it could be the lack of the hormone telling you to make blood, but the last thing was the question of, well, what if you're not missing iron? What if you have plenty of erythropoietin, but something's wrong with your bone marrow? And so what could you do to fix it? And it's not a matter of adding something because you're not missing it. It's a problem of something wrong with the marrow. And you saw some pictures of people, let's say, with leukemia. How do we get rid of it? And, well, you might be able to get rid of the leukemia with the chemotherapy, but the problem with chemotherapy is that it may kill off the remaining normal cells. And we depend, therefore, on this, which is the pluripotential stem cell. And I'm giving you a concept first, that is, we all hear about this. You hear about stem cells. It's a political football, as you well know, where if you take the most primitive cell, you can make anything. You can make a new heart, you can make new lungs, or potentially certainly can make heart cells and lung cells, and you certainly, the easiest thing to do is make new blood cells. And that's because in our body, we have a repository of these young stem cells that when you stimulate them, you can stimulate them into being one of these other cells, or particularly we're going to talk about, you can stimulate them to be a blood cell, whether it be red cell, white cell, or platelets. And of course, if you stimulated them and they grew up, that'd be nice, but then you'll have none left. So not only are they the most primitive blood cell, not only are they the source, but they are able to replicate themselves. Not only do they make new red cells, but they make new stem cells to sit and be there when you need them. Okay, so that's concept number one. Concept number two is already been alluded to, is that here we have that famous stem cell up here, and under the right conditions, it can become what we call a young myeloid cell or a lymphocyte. The myeloid here is the Latin term, which really means blood cell, not white cell. And under conditions, in this case, you can make a white cell here, a red cell, platelets, or all the other kind of cells that we've been talking about. And also our lymphocytes, which help fight infection. So if you said we have a damaged bone marrow, then wouldn't it be just easy enough to take that stem cell and replace it, the bad bone marrow, with the good bone marrow? And that is the concept of, quote, a bone marrow transplant. And now the term has been changed to for the very purpose of what I just said, it's not a bone marrow transplant, it's a stem cell transplant. You're taking stem cells and then they're becoming normal cells again. So, what is the rationale? I've sort of introduced it already. If we have tumor in the bone marrow or tumor elsewhere, we may need a certain amount of chemotherapy to kill those cancer cells. And unfortunately, we will kill the normal cells also. And so what we depend upon is these stem cells to rescue the body. And if you go over a certain amount of chemotherapy, there is no rescue. You will have no stem cells left. And so you need a source from somewhere else. And so if in those diseases where you need to escalate the chemotherapy to get rid of all the disease, and you're destroying the bone marrow, then we would get some stem cells either from yourself and store them away before we do this, or from somebody else. So we have the term autologous, which means from ourselves, and allogeneic, from somebody else. And then we harvest them, we put them in the freezer, and we wait. We get rid of the disease, and then we give back the stem cells. And believe it or not, you just give it in a blood transfusion. The stem cells float into the blood, but they grow in the bone marrow. So when they find the bone marrow, they say, "I am home," like a homing pigeon, and start to grow again. Sounds simple, but it isn't so simple. And so that is the, well, I'll come to this in a minute. I'll say it later. And so that, well, let's start with our own bone marrow. Well, the problem with our own bone marrow is it may be infected with the tumor. I should do this, I'm sorry. It may be infected with a tumor. And so how are we going to get normal bone marrow stem cells from ourselves? And often what happens is we give chemotherapy. We get rid of 99% of the tumor, but there are certain indications, certain ways you can predict that this tumor is not a good one. It won't stay away. So while you've gotten 99% gone, you take the person's own stem cells out, then you give them what would be a lethal dose of chemotherapy, certainly lethal to the remaining 1% of the tumor, but lethal to their own stem cells. But you got yours stored away. As soon as you give the chemotherapy, you give it back, and lo and behold, the bone marrow grows. And I'll explain the problems with that, but that is the simplest and actually the easiest. And I can tell you that doing that procedure, there is certainly less than a 1% chance of dying from all of this treatment. Now, that doesn't mean that you got rid of the disease. You tried to with all the high-dose chemo and so on, but it is relatively easy to do. However, if you have a bone marrow which is filled with tumor that you can't get rid of, or you have a bone marrow that's empty, as in aplastic anemia. So I'll give you the example. When Chernobyl went up, people were exposed, particularly the workers at the plants, were exposed to lethal doses of radiation. That radiation killed their own stem cells as well as their own bone marrow. There was no recovery. They would die. And they sent over a team from the United States to and got bone marrow and started replacing that bone marrow into these patients with aplastic anemia. So in that case, this is not, tumor is still present, but lack of any bone marrow cells. But of course, where are you going to get it? You're not going to get it from the person because he has a damaged bone marrow, and you have to get it from somebody else, and hence the term allogeneic transplant. Okay, so let's start with autologous. This is a diagram that comes from the Leukemia Lymphoma Society, which basically says, okay, we take the patient, we got rid of his tumor, or 90% or 95%, we take out his stem cells, and we store them away. All right, now we are free to give chemotherapy that will kill the remaining tumor, but also kill the remaining stem cells. So there'll be nothing at that top of the list that I showed you to repopulate the marrow, but we take it out of the freezer 2 days after the chemotherapy and give it back to the patient. Within 7 days, you see the recovery of the marrow. So, what's good? Well, as long as you can get your own stem cells, you don't go looking across, you don't see this big public relations thing where let's all sign up to give bone marrow because poor so-and-so needs a bone marrow and doesn't have a match. You have your own, you're walking around with it. As long as you can get it from the bone marrow, and I told you there's the situations where you can't get it, it's a ready source. I told you that it has a low mortality because you're dealing only with getting through the high-dose chemo. As long as you don't have other significant medical problems, there's little age limitation. We can do this up to 70, 75 years of age. and there's a very high response rate. Unfortunately, that high response rate means the bone marrow grows back, the tumor shrinks, but there's no, depending on what tumor you're dealing with, it still can grow back, and there's different percentages for each kind, and I won't go into that today. But suffice it to say, for those people who had a tumor that was destined to grow back, or that where you couldn't get rid of it with a regular dose of chemotherapy, this has provided anywhere from a 30 to 50% cure rate, depending on what we're dealing with, as a way of salvaging those patients. Now, again, certain diseases are not going to respond to chemotherapy, high-dose chemotherapy. If you have very bad lung cancer, so on, we don't do that. But particularly with hematologic cancers, they tend to be sensitive to chemotherapy. They just may need so much that you have to find a source of stem cells. So yes, the person still has to be in good health. Obviously, the high dose of chemotherapy can damage your kidneys, your lung, your heart. So you can't go in there, and this limits the older population who may already have heart disease. And of course, if the disease is growing wildly, there's no way you're going to get rid of it with a chemo. So the stem cells are not going to rescue anything. And so we tend to use people who are under 70 years of age, but we can go up if they don't have any of the others. Wow, sounds like a panacea. Let's do this every day. Well, we don't do it every day. And the problem is that, first of all, if what you're depending upon here is the chemotherapy to kill the tumor, the stem cells are just rescuing it. So people come up to me all day and says, what about a bone marrow transplant? I'm going to give you my bone marrow. I'm going to take somebody else's bone marrow. Well, that's very nice, but if you can't get rid of the tumor, what is the bone marrow going to do for you? And unfortunately, in many patients, you have a very aggressive tumor. It's already been treated. It grew back. You try and salvage them with giving more chemotherapy. But if you can't get rid of the chemotherapy, don't continue and go to the transplant. So then the second problem is, I told you, where are we getting the stem cells? But from ourself. And ourself, I told you, if we killed 99% of the tumor, has 1% tumor in, and it may be circulating in the blood when you collect the stem cells. So you may be giving back some of the tumor. And these are all reasons why people fail. What also is that one of the problems with cancer is, why the hell did I get this cancer in the first place? And in particular, if you started out with one abnormal cell, why did not the body recognize it as abnormal and the immune system get rid of it before it became 2 and 4? And then it's because there's something called immune tolerance. It tends to be more immune tolerant as we get older, since we see more cancer as we get older. And so what we'd love is not only to get rid of the disease with chemotherapy, but if we could teach the body to attack these cells as foreign. And of course, when we give back our own stem cells that weren't rejecting this tumor in the first place, we don't have that. But you'll see we'll have that in a minute when we talk about allogeneic transplant. Of course, if you have tumor in the marrow, you can't get stem cells, or if you have an empty marrow, or what happens is, I told you the patient got chemotherapy, he relapsed, maybe I could get rid of the tumor with chemotherapy, but the stem cells have been damaged from the previous chemotherapy, and there's not enough of them. So if that's the case, what else could we do? And what else we can do is get a ready source of presumed healthy bone marrow from somebody else. And that's called the allogeneic transplant. So it provides this stem cells to replace, and here's a healthy bone marrow with the fat that you saw before and the cells in between. Not only that, but since the stem cells comes with immune cells that have never seen this tumor, these immune cells are not tolerant, and they often destroy the remaining malignancy in themselves. So they deliver what's called an immune-mediated effect. So the process is very similar to what I showed you before. This is patient. He he has refractory disease. We gave him some chemotherapy to reduce the amount, but not enough that we could take his stem cells out. So we get stem cells from somebody else, and I'll explain that in a minute. And we give him now that huge dose of chemotherapy like we did before. But what's going to rescue him is not his own stem cells, but donor stem cells. But you notice there's a little piece of thing that says HLA matched, which means histocompatibility loci antigen. Believe it or not, white, black, or otherwise, we have a system of in our body where we have a way for our body to recognize what is body and what is foreign. And these are these antigens. So your immune cells say, this is good, but this streptococcus that you got, that's bad. It doesn't have any of these antigens on them. I'm going to attack it. And unfortunately, that means that our body can recognize the blood cells of somebody else and attack it also. And so that you will find that there's a set of at least up to 10 loci that are checked, at least 3 from mommy and from daddy, and you look for a match. And again, as I said, you can find this match that can come from somebody who's white, who's black, and Asian, but given the years of separation, there are more or less certain HLA types that are more in the whites than in the blacks than the Asians, and this leads to a limited pool. If you want to find HLA matched people, if there's a problem in finding the match unless you're going to the same ethnic group. So, what are we doing? We have this same chemotherapy which kills the cells. We are not contaminated by tumor cells, so we don't have that problem. We can, if the bone marrow repopulates the marrow and the chemo killed the tumor, have long-term survival. And more importantly, the immune cells, these healthy immune cells from the donor, can attack the 1 or 2 cells that may be left behind, and this is the immune-driven anti-tumor effect. And this has been seen time and time again, where if I take a twin who has leukemia, and is a perfect match from her sister, if she has a higher relapse rate than if I take somebody else's who's a match. Well, you'd think her sister was exactly like herself, that would be perfect, but her sister's immune cells recognize her body as normal and don't attack the tumor cells. So we depend upon this graft versus tumor, but the graft also recognizes the whole body as foreign, and that's called graft versus host disease. That's why they have to be matched in the first place, and I'll tell you all about that in a second. And even if they're matched, there's the immune cells recognize the liver, the lungs, the skin, all of them could be recognized as foreign. And so here's this patient who just came off chemotherapy, who's just recovering the marrow, and all of a sudden the immune cells start attacking his body, so you have to give him immune suppression. Of course, that leaves him open to infection, and so there is a high mortality rate. So if I had my druthers, I'd want to do an autologous because there's less mortality, but I've already told you there's situations where you can't use that, so you try and find a match. And because this is so hard to do, and there's an age limitation, and as I've hinted at, there's a donor limitation. So in the end, there are many more autologous and allogeneic transplants. Okay, so I just said that a stem cell transplant offers a chance. If regular chemotherapy does not cure you, high dose might, but that same process that Dr. Gardner said of you need a bone marrow for the bone marrow to grow, means that you have to replace that marrow. So we often do that in diseases that we know are destined to relapse from certain clinical situations. So once you get them down to minimal amount of disease, you replace the marrow. Well, you won't. You give more chemotherapy and you replace the marrow. Or in a person who's proven to fail the first time, that allogeneic transplants are more toxic than autologous ones, but there are less relapses because of this graft versus tumor effect. Our biggest problem is the limited donor pool. The chance of any one of you matching another one of you in this room is at the minimum 1 in 20,000 to 1 in 50,000. So you need a huge pool. And of course, we have this problem with the toxicity of the drugs. So how can we get around those problems? And this is partly happening, partly science fiction. How can we increase this? Well, many of you have had this situation where your children, your children this era, not younger, are having babies, and they're offered the chance to store away their baby's cord blood. In that cord blood is stem cells. And so the idea is, if baby needs a transplant, we've stored away his stem cells before he ever got sick. Problem is, baby's not going to need a transplant. It's very few babies get that sick and need a transplant. But there are millions of babies born every day. And not only that, there are millions of Chinese, black, white, so that the pool gets bigger every day. And so that if I said this was 1 in 20,000, 1 in 50,000 match, if I had millions to match with, in fact, it's an 80 or so % chance if you're white to get a match from some donor cord blood. It's up to about 50% if you're black. Just represents those who are storing away blood and the number of people in the United States. But this is also going on across the world, so that if we can't find a donor in the registry, and I'll tell you how that's done in a minute, we can expand our pool dramatically by using cord blood. There's a lot of problems because it's just a baby has a limited number of stem cells. You may have to use more than one cord blood, but it's a way of expanding that pool dramatically. The second is, I told you that they get into trouble because you have to give all this chemotherapy to kill the tumor. Then you give back the stem cells, and right away you got to put them on immunosuppressive drugs because you don't want the stem cells to kill the body. But what if you didn't have to give as much chemotherapy? And that's called reduced intensity chemotherapy, and probably a huge number of them are now anybody who's over 50. If we have confidence that we can have the tumor kill the immune cells kill the tumor, that is the graft versus tumor effect, then we don't have to depend so much on the chemotherapy doing that. And so there's a whole group of diseases where we have more, we can affect the immune cells. One of those ways is actually, and this is part science fiction, but they're doing it in a few cases, you can stimulate the donor, in other words, vaccinate the donor so his immune cells are already preconditioned. Then you take them out and go after the tumor. That's part of the third thing. And then what if I told you this guy had chemotherapy, I can't get enough stem cells out, I have half the number I need, I don't want to really go to somebody else's stem cells, I may not have anybody else's stem cells. Why don't I take those stem cells and grow them outside the body, expand them, keep the ability to and then you'll have enough. And that's called stem cell expansion, and that's being investigated. When you see, and we're just about finished here, when you see all these blood drives and bone marrow drives, poor so-and-so needs a bone marrow, and particularly, and you are the brother or the sister, you happily give your blood to see if you're a match, but there's only 1 in 4 chance that you will be, just from genetic reshuffling, so to speak. So you may have to look elsewhere. But those brother and sister are not lost to the system. They've been typed. They go into a registry. And there is an American registry. There is an international registry. There's a Taiwanese registry. There's a Chinese registry. And so that, again, if you have, say, somebody from one part of China or another, you may start looking for that match elsewhere. When they ask 100 or 1,000 people to come in, I told you the statistics are that it's 1 in 20,000, they're not going to find a match. But those 1,000 people go into the registry. And so there is this pool that we have, and when that pool doesn't work, we go to the cord pool, and so that we have an increasing number of people who have been typed. We know that they may be needed in the future, and it's kept on record. And so you're having this expanded pool, and hopefully we're working on A, more people are eligible, and B, reducing the toxicity, because I don't want to minimize the fact that this is not for the faint-hearted. Giving that huge amount of chemotherapy to kill the tumor is not easy. It wreaks havoc on not only the tumor, but the rest of the body. Giving back the bone marrow is simple. But then if you have this graft-versus-host disease, now you have literally an autoimmune disease and need to be taking drugs for a long time, and this all limits the ability. But this is one, so obviously if we can get rid of the tumor without a transplant, thank you, but this is an option to replace that bone marrow that Dr. Gardner spoke about, that unhealthy bone marrow, and deliver a more healthy one that you can live with. And I stop there.